All right, welcome to the clinic, everybody. It is absolutely fantastic to have so many new clinicians joining the team today. As a senior physical therapist here, a huge part of my role is helping you make that jump from the classroom right onto the clinic floor. So today we're going to walk through this explainer together, and we're looking at the reality behind one of today's absolute most popular physical therapy interventions, dry needling. We're going to dive into the data, the safety, and how you actually make the right call when a real, living, breathing patient is sitting right in front of you.
And that brings us to a really critical question, one I want you to literally keep in the back of your mind for your entire career here. Are we treating patients with solid evidence or just pure enthusiasm? Look, it is incredibly easy to get swept up in the newest, flashiest tools. We all do it. But as healthcare professionals, our first duty is to our patients, right? And that means we have to critically evaluate the tools we're using in the clinic, no matter how popular they might seem.
Okay, let's jump right into section 1, the dry needling trend.
So there is absolutely no denying the global excitement around using needles to treat musculoskeletal pain. I mean, patients are actively coming in and asking for it by name. But before we go any further, let's make sure we clearly define what this intervention actually is, just so we're all operating from the exact same baseline today. Basically, dry needling involves the insertion of really thin, filiform needles directly into hypersensitive spots, what we call myofascial trigger points. The goal here is to mechanically disrupt the dysfunctional neuromuscular activity in that tissue. It potentially gets you that local twitch response and ultimately decreases muscle tone. Pretty straightforward, right?
Now, we do have to briefly contrast this with acupuncture, just so our patients and, hey, even some of our new grads don't confuse the two. They are completely different theoretical frameworks. Dry needling is strictly based on Western medicine. We're targeting specific anatomical trigger points for that neuromuscular disruption I just mentioned. Acupuncture, on the flip side, is deeply rooted in traditional Chinese medicine, targeting acupoints along meridians to balance vital energy, or qi. So it's the exact same tool, but entirely different paradigms.
Moving right along to section 2, searching for solid evidence. Whenever an intervention gets this unbelievably popular, we've got to look for high-certainty evidence to back it up. Enter a major 2026 systematic review of systematic reviews by Jenkins and colleagues. These researchers basically started by casting a massive net. They searched 5 major databases and initially pulled in over 5,000 records. 5,000! But through a really rigorous screening process to make absolutely sure they were only looking at the best available synthesized data on dry needling for MSK pain, they filtered that huge pile all the way down to just 38 systematic reviews.
Which brings us to section 3, the bias in the data.
All right, step into the shoes of a lead investigator with me for a second here. Out of those 38 final reviews, how reliable do you think they actually are? Well, using a super strict tool called ROBUS, that's the risk of bias and systematic reviews tool, we hit a really stark, honestly jarring statistic. An overwhelming 82% of these 38 systematic reviews suffer from a high risk of bias. Just pause and think about what that means for us as clinicians. More than 8 out of 10 major reviews telling us how great this highly popular treatment is actually have fundamental methodological flaws that could totally skew their conclusions. Yikes!
When we break down the data to see exactly where they're failing, we're looking at an absolute sea of red warning flags across the different domains. Notice that the domains for data collection and study approval and synthesis and findings are just completely dominated by high risk. This really visualizes the severe methodological flaws in our foundational evidence. It literally means the way the data was gathered and how it was ultimately put together is highly questionable in the vast majority of these papers.
So the crucial point is this. Out of all 38 systematic reviews analyzed, only one single review, just 3%, demonstrated a low risk of bias. Seriously, I want that to sink in for a moment. Trustworthy, high-quality synthesized evidence is incredibly rare for this specific treatment right now. If we're making clinical decisions purely based on the current literature, we are basically building our practice on a very, very shaky foundation.
Let's look at what that means for our practice in section 4, assessing patient safety risks.
As PTs, we obviously must always rigorously evaluate potential harms, not just the benefits. Dry needling is an invasive technique. We're breaking the skin, we're entering muscle tissue. And the Jenkins paper reveals a frankly terrifying fact. When looking at those 38 reviews, 45% of them didn't even bother to report on potential harms. Another 5% only incompletely reported them. That means for half of the summarized evidence out there, we are essentially flying blind regarding patient safety. If the harms aren't reported, it's impossible for us to know if they simply didn't occur or if the researchers just ignored them completely.
But hey, let's look at what we actually do know from the 50% that did bother to report. We can break down the documented adverse events into minor and moderate harms. Minor harms are things you'd probably expect, like bruising, bleeding, and some post-needling soreness. Now, moderate harms are rare for sure, but they are very real. These include syncope, which is fainting, severe pain, and even presentations to the hospital with a systemic upset of fever and chills. We absolutely have to balance these realities.
And I really want to remind everyone on the team here that while those severe hospital-level issues are rare, the minor harms are not. In fact, they're extremely common. Based on large surveys of clinical practice, minor bleeding, bruising, and soreness happen in about 36 to 40% of sessions. Guys, that is well over a third of your treatments. This makes upfront, radically honest patient communication absolutely vital before you ever pick up a needle.
Okay, final part. Section 5. Navigating clinical decision-making.
So how do we actually move forward and integrate this pretty sobering data into our safe, everyday clinical practice? First off, I want to reassure the team. If needling feels a bit risky right now given the data, remember that we have a massive, deep toolkit of other multimodal approaches. For the vast majority of MSK conditions we see, there are alternative treatments with a much higher certainty of benefit. Exercise therapy, manual therapy, really solid patient education, and behavioral strategies. These are the safe, proven pillars of physical therapy.
Let's walk through our clinic's protocol to see how we build a safety net. If you and your patient discuss it and decide dry needling is still the most appropriate route, you've got to follow this step-by-step workflow recommended by major physio associations. Number 1, act strictly within your trained scope. Number 2, gain full, documented, informed consent, making sure you actually detail those 40% minor harms and the rare moderate ones. Number 3, minimize needling in high-risk areas, like the thorax. And number 4, thoroughly screen for contraindicating medications or medical conditions. Doing this protects both the patient's health and, honestly, your hard-earned clinical license.
To sum up the ultimate scientific takeaway from the Jenkins researchers, they say, and I quote, "Due to the high risk of bias in most systematic reviews, clear clinical recommendations for dry needling in the management of musculoskeletal pain cannot be confidently made." Basically, until the data improves, until researchers start using better reporting guidelines, and until we finally get high-certainty evidence, we just have to proceed with extreme caution.
So, I want to leave you with a powerful challenge to your clinical philosophy as you kick off your journey with us. When you step out of this room and onto the clinic floor today, are you going to prioritize the allure of a popular trend or the undeniable safety of your patient? It's always a delicate balance between seeking patient relief and ensuring patient protection, right? But I'm incredibly confident that by leading with the evidence, you're going to make the right call. Thanks so much for joining me on this explainer, everyone, and let's go have a great day in the clinic.